everyone. My name is Kieran McNellis, and I am one of your co-hosts for today's Redesigning Sepsis Care conference. I'm a first-year medical student at Sidney Kimmel Medical College in the Scholarly Inquiry Design track.
And my name is David O'Connell. I'll be co-hosting alongside Kieran today, running the second half of the conference. I'm also a first-year student at SKMC in the design track. Really looking forward to what we have for you today.
So first of all, we just want to say thank you all so much for joining us today. Our fellow students have worked so hard this year on their projects, and it means so much to us to have the ability to present our work to you during this conference today. We're coming to you live from the Jefferson Health Design Lab, located on our Center City campus. Sidney Kimmel Medical College's Scholarly Inquiry Design track, also affectionately termed SI Design, is the first co-curricular design thinking program at a U.S. medical school. It is now a curricular track within the JeffMD program at SKMC. The students in this track, like David and I, and everyone that you'll see presenting today, learn how to think like designers and gain experience for working in teams and in transdisciplinary teams. The Health Design Lab exists to bring people from different backgrounds together and promote inclusive design in healthcare. From patients to providers, we believe that everyone has the potential to accelerate change and improve lives. Fueled by traditional and modern prototyping technology and a foundation of health design thinking, we here at the Design Lab believe that this is a space that will change the way we all think about the future of healthcare. So how exactly do we get from fresh design students to presenting our projects to you today? Great question. At the very beginning of the year, the first year SI design track students like David, me, and everyone else you'll see were asked to redesign sepsis care. Okay, sounds interesting. Sounds like a problem area I could get into, but what the heck really is sepsis? I'm happy to report that I do finally have an answer to that question, but just in case anyone in the audience is as confused as I was a few months ago, I'll share a quick definition of sepsis before our first speaker gets a much deeper look into that. So sepsis is a potentially life-threatening condition that occurs when the body's response to an infection ends up damaging the body's own tissues, and it can lead to organ dysfunction and even organ failure. So now that we've got that out of the way, through the guidance of our sepsis and clinical experts, we were able to transition from what is sepsis all the way up to how is sepsis care delivered and how exactly can we as students aim to improve the care delivery. That is the exact question each of our teams will be answering today. We will have 6 student teams, each presenting 6-minute pitches about their ideas that they've been working on for a multitude of months. They're all aiming to tackle the current challenges within sepsis care with reimagined solutions in order to improve sepsis outcomes. We really want this conference to be as interactive as possible, so there will be designated time at the end of each pitch to provide feedback as well as ask any questions you may have. We will also hear from 2 incredible speakers, Dr. David Gaieski, who is a clinician and sepsis expert, and April Chavez, who is a maternal sepsis survivor and patient advocate. We are so grateful to have these speakers here with us today, and I'm so excited to have the privilege of introducing our first speaker, who will provide us with a much deeper look into exactly what sepsis is. Dr. David Gaieski is a professor, vice chair for resuscitation services, and director of emergency critical care at the Department of Emergency Medicine at Sidney Kimmel Medical College. Dr. Gaieski attended the Perelman School of Medicine before completing a residency in internal medicine at the Hospital of the University of Pennsylvania and an emergency medicine residency at Christiana Care Health System, followed by a fellowship in non-operative sports medicine at the Hospital of the University of Pennsylvania. His research expertise focuses on resuscitative sciences, care for severe sepsis, and septic shock, with a focus on improving our understanding and treatment of sepsis, as well as cardiac arrest resuscitation. Thank you so much, Dr. Gaieski. Go ahead.
I'm Dave Gaieski, and I am an emergency physician here at Jefferson. The other thing is I'm the enterprise physician lead for sepsis quality improvement. So I am going to share just some quick thoughts on sepsis and what sepsis is with you. And that was a perfect definition that we already heard. That's sort of the modern 2022 definition. And I'll just run through a little of the background of sepsis and why it's a difficult thing to detect in some ways and why we pursue early screening strategies. So a few disclosures, just so people know. As I said, I'm the physician lead for sepsis quality improvement. I've also have some active work partnering with telehealth companies and Jefferson Strategic Ventures and a screening company called Ambient Dart from the Mayo Clinic. And then the telehealth company is Teladoc. I also do some scientific advising and consulting for early diagnostic companies, including Instant Diagnostics and Patched. So no other disclosures. I'm going to talk a little bit about what the problem is. Why do we care about sepsis? Some of the changing definitions, detection. I'm going to actually leave out most of lactate as a risk stratification tool because we did not have time for that. Well, I'm saying my camera's on, not on. When I tried to turn my camera on, it said I wasn't allowed to start my video. So if you want me to start my video, I'm happy to, but I need to be able to do that. Do you want me to try again? Okay, can you see me now? Thank you. Here we go. So what's the problem with sepsis? So why is this important? Here's just some data. Most of this is older data, 10 years old. Most of the numbers have increased, but at one point in time, people quoted the fact that a patient a minute presents to a US ED with sepsis. That's clearly probably several patients a minute at this point in time. Back then, the most famous study on sepsis epidemiology in the United States was from Derek Angus at the bottom right there at University of Pittsburgh. And they said there were 750,000 cases a year of severe sepsis in the United States. We'll get to what severe sepsis is. That about right in the neighborhood of 30% of those died, so 215,000 deaths a year. There's probably up in the 350,000 deaths a year from sepsis at this point, even though care and mortality have improved. Then it was the 10th leading cause of death in the United States. It's the first leading cause of death in hospital admissions in the United States. And when this was the 10th leading cause, pneumonia was the third, but you don't die of pneumonia without having sepsis in general. So an issue too, and you'll see this in the study I show you next, is that the rate of sepsis is increasing faster than the rate of population growth. And that's because we do a good job at keeping people alive for longer with multiple medical problems. We also have more immunosuppressed patients, more patients who are on chronic steroids, other drugs like that, more people undergoing chemotherapy. And this is where this fits into sort of what I trained in and stuff, is that 70 to 80% of cases of severe sepsis present through the emergency department. So we're really the place to start treating this and study this. This is a paper we published in Critical Care Medicine back in 2013, and this uses different techniques to capture sepsis patients, but it's using people that are coded for severe sepsis or septic shock. So people acknowledge that they have that, or they were coded for sepsis, which back when we did this work meant an infection and inflammation, but no acute organ dysfunction. Then they also were coded for an acute organ dysfunction. So people didn't use the specific code. But the thing to look at here is this middle dotted line. That's the mean weighted average of all these patients. And you can see 2004, 1 million cases, 2009, 2 million cases. This increase because of population and disease comorbidities, but it's also an increase because more attention's being paid to sepsis. So more people are actually being coded appropriately with that. The good thing is during this time, you can see the mortality decreasing, and we don't have a mean weighted average on this graph, but you can see the more specific ways to capture these patients. The mortality went from 32% or so down to 20%, and the more sensitive ways that have more patients in them went from about 18% to 13%. What I will say about all that is that it's improving care, it's improving coding, improving documentation, but it's also way too high mortality. So one of the reasons we spend time thinking about sepsis is to try to increase the survival more. So sepsis is not a new term. In going back to Homer, he described sepsis from the word sepo, which means I rot, and Hippocrates talked about sepsis as a dangerous biological decay that could potentially occur in the body. And I think that one's interesting because it's not that far from some of the modern ideas of sepsis. So this is Osler, who's considered the father of American medicine. He was at Penn in 1884 to 1888, and then went down to Hopkins and up into a hospital in Canada and then over to England. And interestingly, he died of sepsis, probably an influenza-related sepsis. But this is one thing he said about sepsis, that except on few occasions, the patient appears to die from the body's response to infection rather than from the infection itself. And this was observations that he made watching patients who had gangrene from battlefield injuries, and then looking at them and seeing how their body responded after they had an amputation. And there seemed to be some amplification of a process, and we would know that now as the inflammatory and anti-inflammatory processes in the body. So you can get sepsis from lots of things. This is just a paronychia, infection under your fingernail. I've taken care of a couple of cases of septic shock from this. Obviously, the person has to let it go for a long time, because if you treat that early, we can just slide a needle under the skin there, drain the pus, and you're good to go. But if you let it go for too long, you can get really sick. Necrotizing skin infections. This is a mosquito, and this is falciparum malaria, and you can have septic shock from that. And then this is an intubated patient with ARDS from strep pneumonia, and you can see socked in lung on the right side, and someone who's going to have a rocky course of sepsis. So this is from a good review article in New England Journal from Derek Angus back in 2013 on severe sepsis and septic shock. And really what's going on with sepsis is there's an infection, and then there's a host response to that infection. And that's what Osler was talking about, how the host response could hurt you. So you get a pathogen. It can be a virus, it can be a bacteria, it can be a parasite. And there's lots of things related to that pathogen. How much pathogen did you get? What's the virulence of it? And then how does that produce these PAMPs, these pathogen-associated molecular patterns? And then you get your cytokine response to that, your cellular response. And this is really where a lot of the injury comes from. And that's true with bacterial infections, but it's also been true during the COVID pandemic. So let's just run through some of the definitions and get to the definition we heard in the introduction, which is really the modern definition, and talk just a little bit about where that all came from to put this into context for you. So the first international sepsis definition came about from a conference of the American College of Chest Physicians and the Society of Critical Care Medicine back. The conference was in 1991. The article was published in the journal Chest in 1992. And this conference was held because people felt like they didn't have a unified definition of sepsis, that they were doing a lot of large clinical trials in the 1980s of sepsis, and they were studying these drug interventions. So they had tumor necrosis factor receptor antagonists. They tried high dose ibuprofen, high dose steroids. They tried blockers of endotoxin, lots of different things. And all those studies were either negative, meaning the intervention actually caused harm, or they were neutral, meaning there was no difference between the trials. And one thing people thought was maybe a very heterogeneous group of patients was getting enrolled in these studies. So they tried to come up with some uniform definitions. And this is what they said: it was the goal of this conference to provide both a conceptual and a practical framework to define the systemic inflammatory response to infection, so the body's response to infection, a progressive injurious injurious process that falls under the generalized term sepsis and includes sepsis-associated organ dysfunctions as well. So there's an infection, the body's response to that infection that can be either protective or injurious, and then that can lead to organ dysfunction, and those organ dysfunctions are what lead to morbidity and mortality. So this is the continuum of sepsis they came up with, and they said, so there's this inflammatory response, we'll call it the systemic inflammatory response, or SIRS, and these are what they said it consisted of: either a high temperature or a low temperature, a rapid heart rate, 90, so less than what a cardiologist would call tachycardia, which is greater than 100, and then a rapid respiratory rate or alterations in your chemistry, suggesting that you're breathing fast and blowing down your CO2, or an elevated low white count or an increase in immature cells. And that's what the SIRS response is. And this actually came about, they basically took one of the negative clinical trials of high-dose steroids in the 1980s, and they said, let's look at the control group. They didn't get any intervention. And when those people arrive in the ICU, what common physiologic variables do they have? And they said 95% of the people have 2 or more of these. And that's where the SIRS criteria came from. It's wasn't tested or anything. They just threw it out there. And then they said, when you have those with a suspected or confirmed infection, then you have sepsis. So you don't have any acute organ dysfunction at this time. And they made this famous Venn diagram that's been shown over and over again about here's SIRS, here's other things that can cause SIRS, trauma, especially blunt trauma, burns, pancreatitis, and then all the infectious etiologies. And when you have both the infection and the SIRS, you have sepsis. And what this shows you is like you can be bacteremic and not have sepsis. You can be bacteremic and have totally normal vital signs. But if I took you and stuck you in the corner of the emergency department and said, watch TV and gave you a tuna sandwich, we could watch the natural history of sepsis. You would start to have a SIRS response and you would develop organ dysfunction, hypotension, shock. And one of the other interesting things here is all these things that cause a SIRS response are related to simplifying the leakage of intracellular contents into the extracellular space. And what happens when you do that? You leak mitochondria. And what are mitochondria? They used to be bacteria. So the body recognizes mitochondria as bacteria. And when the body sees mitochondrial components, it produces a SIRS response. So this all makes sense physiologically, and I think that's pretty cool. When you add in acute organ dysfunction, then you have what used to be called severe sepsis. You can have kidney dysfunction, coagulation dysfunction, mental status changes. Some people would say this is not an organ dysfunction, it's a sign of tissue perfusion. So when you have an elevated lactate, you have decreased tissue perfusion, hypotension that doesn't respond to fluids, myocardial dysfunction. So that's what the old definition called severe sepsis. And then septic shock was when you had that hypotension that did not respond to volume resuscitation and was going to require a vasopressor. There's also this concept of cryptic shock when you have tissue level hypoperfusion significant enough to produce a lactate greater than 4 millimoles per liter. And that's a marker for much sicker patients, and that's been correlated with bad outcomes and death. So what about this whole systemic inflammatory response? People started studying it, and then they said, how does this correlate with sepsis? It was used in some famous trials. This is the inclusion criteria for the Rivers goal-directed therapy trial from 2001, which is probably the most famous sepsis trial ever performed, and they used the SIRS criteria. Here's the paper that came out in 2015 that started people saying we need something other than SIRS criteria. This is from Kaukonen's group over in Australia and New Zealand. It's called the ANZIX group. It's a critical care research group with 170 hospitals or so over there. And what they looked at here was patients who had SIRS criteria when they got to the ICU versus patients who didn't but were septic, and lower mortality unadjusted if you didn't have SIRS criteria. So they showed that the SIRS criteria were about 88% sensitive for capturing these ICU admitted sepsis patients, and said, wow, that 12% is unacceptable. We need something different. So they came up with something different in the third international definitions, but I would argue that something different was not helpful. So in the third international definitions, we hear a definition very similar to what we heard earlier: life-threatening organ dysfunction caused by a dysregulated host response to infection. And they said, because the SIRS doesn't work 12% of the time, we're going to get rid of it. And then we're going to have this thing we're going to call QSOFA. So the SOFA is the sequential organ failure assessment score, and it's a way of measuring how sick patients are over their hospital course. It's measured every 24 hours. And they extrapolated from that and said there's this bedside score you can do looking at blood pressure, respiratory rate, and mental status. And if people have 2 or more alterations of that, then they're at risk for having sepsis with a high mortality or a long ICU stay. So is that true is the question. And what they said here was these patients would do that. I sort of already mentioned that. This is a paper we published 2 years ago looking at that. And we said, okay, someone comes into the emergency department, they have SIRS criteria, but they have 2 QSOFA points. So yeah, their mortality is higher, it's 26%. If they don't have 2 QSOFA points, their mortality is still 11.7%. But the more important thing is if you're trying to use that as a screening tool in the ED, here's 2,900 patients with severe sepsis and organ dysfunction with a mortality of 17% overall, and only about 20% of them are captured in the emergency department by QSOFA. So it doesn't work. What if you gather it over the entire ED stay? Well, it captures more patients, so therefore your mortality goes down, but it still misses this group of patients that have 8.5% mortality that we could maybe modulate and lower if we captured them sooner. So you can't use this as a screening tool. The definition makes sense pathophysiologically, but the definition can't be translated into a way to capture these patients. This is the flow diagram they gave in the third international sepsis definitions in JAMA. And if you look at the upper left here, what they say doesn't make a lot of sense to me. They say the patient has a suspected infection. Yes. Okay. Is their QSOFA greater than or equal to 2? Yes. Okay. Assess for organ dysfunction. No. Do you still suspect sepsis? Well, this took about 30 seconds. Why would my mind change and say, oh, I no longer think they're septic, I'll just monitor them? So you basically end up in the same place assessing for organ dysfunction. So they acknowledged right off the bat that they weren't sensitive enough using QSOFA, and this suggests you need to apply something else to it. So what would that something else be? If their QSOFA is positive, then you're going to go down here and assess for organ dysfunction. If their QSOFA is negative, you're going to ask yourself, that question, and the answer is going to be yes, because you already just asked it to yourself. And then you'll check their SIRS criteria. If their SIRS are also negative, then yeah, you can monitor for a clinical condition, look for other acute occult organ dysfunctions. But if their SIRS is positive, then we should check a lactate and start to get some other labs and assess these patients. So the questions you're asking yourself once you have a suspected infection is, do I suspect sepsis? And what you're asking there essentially is, do I think there's acute organ dysfunction? This is from our most recent iterations of the Jefferson Sepsis Guidelines. And this basically combines screening criteria from SIRS and QSOFA, and then looks at all the acute organ dysfunctions, and then moves on and says, do they have refractory shock or signs of high-level hypoperfusion? So I will end there. I'm just trying to bring you up to the present with some historic background. The key to sepsis is thinking about it and then saying, does this infection have acute organ dysfunction associated with it? And the reason we care is there's a huge epidemiologic burden. Recognition's a major hurdle. The SIRS are helpful. Lactate's a great screening tool that I didn't have time to tell you about, and a great risk stratification tool. Q-SOFA can be used for risk stratification, but I showed you how it's not sensitive enough to be your initial screening tool. We have to screen everywhere, EDs, wards, post-operatively, and then when you recognize a syndrome, you have to start care without delay. And these changing definitions are basically associated with increased knowledge of physiology and pathophysiology. But the bottom line is sepsis is infection, the body's response to it, and organ dysfunction from that response. And we didn't talk about care, but it's fluids, antibiotics, stabilization of the patient, and source control. This is the last thing I'll show you. This is famous article from 1964, Annals of Internal Medicine, and it's about pneumococcal pneumonia with special reference to bacterial pneumococcal pneumonia. If you look at the bottom line here, that is untreated pneumococcal pneumonia with bacteremia, about 8% survival. Then they started doing serum immunoglobulin, just like we do with COVID, and they were able to increase survival up to 50%. And then they invented penicillin, and suddenly we have 90% survival. These are the highest absolute risk reductions in the history of medicine, probably, and of sepsis, certainly. And so that's what we're striving for now in a more incremental fashion. Well, and, I'll stop there, and thank you for asking me to show up.
Gaieski, for that insightful talk. We greatly appreciate your support throughout the past couple of months with our projects, and I'm sure the support that you'll continue to give as we move forward with each of our projects. We're now going to shift to our student pitches. So we're going to have our first group presenting Sepsis Spot, and it will be Haley, David, Lauren, and Zach.
All right, hello everyone. My name is Lauren, and alongside Haley, Zach, and David, I'm excited to introduce you to our project, which is entitled Sepsis Spot. So sepsis is a large healthcare challenge. It is one of the leading causes of preventable death, regardless of age and gender. So to begin our design challenge, we began with the question of how can we use health design thinking in order to earlier identify this complex syndrome. So we spent the majority of our ideation stage determining which population we were going to design for. And in our search, the disproportionate impact of COVID-19 deaths on long-term care facilities, in addition to personal narratives and anecdotes from emergency medicine physicians detailing septic patients from long-term care facilities, really emphasize this vulnerable population to us. So we found many challenges that long-term care facilities face, including low staffing and lack of resources. And this oftentimes results in residents at long-term care facilities not having their vital signs monitored daily. Additionally, residents are often treated as patients who want more autonomy over their own healthcare. So we needed a design solution that would address these gaps.
With these challenges in mind, we came up with the following how might we statement. How might we identify early vital sign changes concerning for sepsis in long-term care facility patients? And we also need a solution that is affordable, effective, reduce burden on staff, and realistic to implement. Research has shown that changes in basic vital signs such as blood pressure, temperature, and pulse oximetry can detect early signs that an infection is developing into sepsis. These tests are also non-invasive, and medical devices already exist that measure them. While developing a solution, we interviewed multiple medical professionals, including Dr. Libby, a geriatrician directing Jefferson's long-term care facilities needs. And through our interviews, we realized that there was a big gap in the timing of vitals monitoring. Currently, residents of long-term care facilities who might only require basic services to help them with daily living usually only have their vitals checked monthly. So what if we designed a solution where residents could have more autonomy over their health and they could monitor their own vitals daily? Their medical data would be immediately available electronically to their nurses and physicians so that the care team can catch an infection early and allow the resident to stay in the facility in their home, avoid the hospital, and ultimately avoid sepsis.
So we envisioned a system that would allow users to measure their own vitals and view them. But there's already precedence for this kind of system. Those blood pressure stations that you see at pharmacies, some of them are even connected to the internet, and they've been used for years with great reliability. So we envision an expansion of this kind of system. It would take blood pressure, pulse oximetry, and also epidermal temperatures. But the real value of our system actually comes from a really basic computer system. It would display these vitals, upload them to the patient's electronic medical record, and then also flag at-risk patients. So what's our vision for this system? We see Sepsis Spot fitting into existing spaces within long-term care facilities. The patient would walk up, insert their arm into an automated blood pressure cuff and a finger pulse oximeter. The vitals would be measured and displayed on a computer. Simultaneously, the vitals would be sent to the patient's EMR, and apparent vitals or trends in vitals would trigger a flag to the healthcare staff, but otherwise no staff intervention would be needed.
Great. So what we wanted to do after considering Sepsis Spot was think about the impact of Sepsis Spot. While designing a solution, it was important for our team to consider, is this something that realistically can impact patients? And then if it impacts patients, will it improve lives? So here's a quick article summarizing the data for sepsis-related hospitalization characteristics. And about 4% of septic patients who have sepsis diagnosed on admission came from a skilled nursing facility or a long-term care facility. They're then often admitted for inpatient care, which carries a huge cost, not only directly in terms of money, but also indirectly on the healthcare system. After a patient's stay, what happens once these patients are discharged? About one-third of patients are discharged to a skilled nursing facility, a rehab, or a long-term care facility. After discharge, within 30 days, 10% of them return to the hospital for complications from their stay. Again, look at the numbers on the bottom of the screen. That carries a high direct cost and also a high indirect cost. When it comes to the cost for improved sepsis long-term care facility care, we also wanted to tie back into how monetary incentives work for healthcare billing. 92% of patients with the ED already have sepsis before being admitted to the hospital. And why is that the case? Can we identify the sepsis before they even get discharged from the long-term care to go to the hospital? And of course, poor infection control in these facilities could be a cause for lawsuits, but more importantly, it could be a cause for sepsis. When it comes to Medicare patient reimbursement, if we're able to increase the amount of sepsis that can be identified with early detection, we'll actually end up returning some of the revenue back to the long-term care facility that could help offset the cost of implementing a solution like Sepsis Spot. It was also important for us to consider the impact of the Sepsis Spot solution on all of our stakeholders, the patient's clinical outcomes, the clinical team, and also the health enterprise, which in this case would be the long-term care facility. For patients, we hope that this solution will directly improve their agency and care, help them feel more satisfied with how they're being cared for. In facilities where care and staff can often be a challenge, we hope this also correlates back to patient vitals and monitoring and improve patient outcomes. For example, increased sensitivity in infection detection, and also improvements to staff communication, especially the communication with patients. We also expect this solution will help the clinical team and also the health enterprise by reducing external transfers and increasing savings. So we wanted to thank you all so much for listening to our presentation introducing Sepsis Spot, and we'd love to hear any questions or feedback that you might have. So the question in the chat from Andres is your approach to responding to abnormal vital signs, have you considered leveraging telehealth for escalating care for a patient who potentially has sepsis? Okay, so absolutely yes. What we envision for Sepsis Spot is have it be a both and solution. So the issue with early detection in long-term care facilities is really the staff that's available to do long-term detection. If there's a method via telehealth to integrate in with this, and maybe it works where if the vitals are screened as abnormal, you'll then engage it with a telehealth provider who can help further screen you for sepsis. And of course, another opportunity for telehealth could be in integrating with clinicians who are sepsis experts like Dr. Gaieski. Maybe there's a solution where if sepsis is flagged, the sepsis expert can be consulted within the long-term care facility, so antibiotics could even be initiated before a patient has to go to the hospital.
Thank you for your question.
I think Zach, you talked about how you would use the already existing like automated blood pressure cuffs to integrate sepsis spot in with that. How many long-term, I don't know if you guys can do this, but do a lot of long-term care facilities in the US already have those automated blood pressure cuffs in their facility? I know a couple places I've visited haven't, but I could have also just missed it, so I don't know.
So we talked to Dr. Libby, who's the geriatrician. Oh, yeah. So the question was, to our knowledge, what extent are automated vital measurement systems, specifically those blood pressure systems, already being used inside long-term care facilities? Our conversations with Dr. Libby, again, this is anecdotal. We don't have actual data on this, but our conversations with Dr. Libby, the geriatrician we interviewed, it does not sound like automated vitals really have been a part of long-term care facilities, especially long-term care facilities that deal with or have elderly patients. I think that's a missed opportunity. It sounds like at this point, especially non-critical long-term care facilities don't take regular vitals on their patients, automated or otherwise. So I think there's a big gap there, and that's kind of the low-hanging fruit we were going for here.
Yeah. Have you thought about your, like, who's going to pay for this device, how you're gonna reimburse it, things like that, what was your payment strategy?
So the question from the room was, how have we thought about our payment strategy and what's the model where we can reimburse this? And maybe also if I can make it sustainable. Is that it? Okay, great. So when it comes to this, the payment strategy initially would be, what we'd have to do is assign a billing code to the sepsis device. And initially it would probably be an upfront investment from the long-term care facility or the skilled nursing facility to fund the cost to develop the solution and customize it for whatever their facility's needs are. So the initial investment is probably gonna have to come from the facility, but maybe there's also other avenues we could think about. There's a lot of foundations that talk about sepsis care, and maybe there's a grant we can plug into to help offset some of that initial cost, or some philanthropy models where a patient who's impacted from sepsis, based off that maybe a poor experience in the long-term care facility, wants to fund the money to make it better. So that's the initial investment. The next thing talks about how can we make it sustainable. While we hope this solution will be perfect, work 100% of the time, things break, things need to get fixed, and maybe a few years later, there's an improved method we can use for early vitals detection. So to make it sustainable, what we want to do is work with insurance companies because this is a risk reduction measure. If we're able to demonstrate the effectiveness of sepsis at reducing risk, then we can potentially demonstrate that the cost to implement the solution offsets the cost that would otherwise be spent on a hospitalization due to sepsis. And when we crunch the numbers, it's the cost for hospitalizations due to sepsis is enormous. And if we're able to think of one patient who could possibly be septic at a long-term care facility, give them antibiotics early, we might even pay for the cost of implementing it just off that one patient and having them avoid a hospital stay. Did that answer your question? Okay, great, thanks. Are there any other questions from the room or from Zoom? So,
Okay, for awareness, Dr. Gaieski and I are working on a business plan for dedicated remote RNs to perform patient monitoring across all of our acute care hospitals. I could see this group being also leveraged down the road if we pursue efforts to improve sepsis care at the long-term care facilities Jefferson has oversight of. Thank you so much, Andres. Any other questions? Thank you.
Great.
All right. Thank you, Sepsis Spot, for starting us off with such a great presentation. We're going to take a quick 3-minute break, so feel free to stretch, grab some coffee, grab some water, whatever you need, and meet us back in about 3 minutes.
Good afternoon, everyone. Thank you for joining us. So we're going to be presenting to you our product, Sepsis Check to Go. Myself, Blair Adler.
I'm Paris. I'm Nathan.
And
I'm Rachel Monane, remotely.
So just an introduction, these are the steps that we followed to come up with our product idea. And in the next slides, we're going to be going through it in more detail.
So we know that sepsis is an enormous burden on the healthcare system. The realm of surgery is no different. So each year there are 2 million surgical infections annually in the United States, all of which are at risk for progressing to sepsis. In addition, surgery patients account for 30% of all cases of sepsis within the United States. Specifically for decompression surgeries, which will be the focus of our intervention, surgical site infections can be as high as 11% for those decompressions. And finally, this is a huge problem because when sepsis happens and is detected late, that can double the amount of time spent in the hospital, in the ICU, and on the ventilator, and lead to worse outcomes. Some of the factors that make sepsis worse are inadequate patient awareness. So on the right-hand side here, we can see a blog post from Rothman, which fails to mention the importance of looking out for signs of sepsis post-surgery. In addition, large travel distances and limited home monitoring for sepsis continue to make this an issue. Most of the home monitors that are available fail to include a lactate test.
Yeah, and so late detection of sepsis is what leads to both poor patient outcome, increased burden on the healthcare professionals, and even an exponential increase in the cost of care. And so our goal is to decrease the time to treatment for post-operative patients by helping those patients monitor and detect their vitals at home remotely.
So the methods that we use, we prioritize affordability, feasibility, usability, and reusability. So we wanted patients to be able to take this kit home with them and be able to return it to us so we can reuse it at their post-op appointment. We did also consider wearables, third-party points of contact, and expedited urgent care testing. So our solution, so we came up with our sepsis kit that has a pulse oximeter, a thermometer, as well as point of care fingertip lactate tests. And basically why we came up with this is because fingertip point of care lactate tests are accurate lactate measurements. As you heard Dr. Gaieski speak earlier, one of his research studies focused on this. And as you can see in the graph provided, we have a very accurate way of using the point of care lactate fingertip tests to notice if there's elevated lactate levels. In addition, the resources that we would use would be the nurse's call line to say if they had elevated lactate levels and the care team.
So to walk you through where sepsis check to go fits into the general patient journey, the patient would start by undergoing surgery, and then they would begin to recover in the hospital. And when they'd actually be able to be discharged sooner, thanks to the remote monitoring that our kit would be able to provide. And so once they go home, they would go home with our kit, and they would, post-op infections generally occur 2 to 3 days after surgery. So the patient would be able to monitor vitals like checking their pulse ox and temperature. And if they were to experience a temperature, they would be instructed to take a lactate test and would have an immediate telemedicine follow-up visit that would allow them to discuss next steps, if it would be more appropriate for them to have antibiotics or for them to actually go to an emergency room to seek immediate care. And then at the end of their journey, they would be returning our kit during their already scheduled follow-up visit with their surgeon.
Yeah, so a major benefit of the sepsis check to go kit is the ease of reusability and also the affordability of the product. And so while sepsis can range anywhere from $16K to $40K of care, depending on how far along the sepsis has gone, our kit is estimated to be around $900 to $1,000 based on industry benchmark tested tools. And given that post-op patients will already have a follow-up appointment scheduled immediately, it will be easy and streamlined and even mandatory for the patients to return the kit to the hospital in the follow-up.
So far, some of the feedback that we've gotten for this idea from Dr. Slovis is that it could be a great addition to traditional post-op follow-up, and it should be easy to implement. And because all these patients are coming back for follow-up, we imagine that we'll recover these kits. Something to keep in mind is that lactate is not unique to sepsis, so we'll have to consider the entire clinical picture of the patient and make sure that they're willing to do this test when they get home.
And in terms of next steps, we're would like to identify kind of those specific use cases for pilot rollout, accounting for the lactate variability and variation that we are expecting. We'd also like to construct a working prototype and get to test those easy to use instructions and make sure that they're user friendly. We'd like to kind of pilot that workflow of the whole patient experience and kind of breaking it down and reusing the kit and determining what the ROI would be for insurance companies who, if they'd be interested in actually providing coverage for the kit in the future.
Thank you very much.
Thank you.
We're happy to take any questions.
You guys mentioned like the importance of the easy to use instructions. Do you think there'll be any sort of like patient learning curve, actually understanding why it's important for them to follow up on these tests after their surgery? Have you talked about it all about like how that patient education is going to happen without the surgeon doing it when they're immediately post-op? How exactly is that patient education going to happen beyond just those easy to use instructions?
So I think that we thought that on their pre-op appointment. Oh, yeah. So her question was, is there going to be any learning or any teaching to patients prior to just expecting them to use it themselves? So yeah, we did. We think that it would be best if they, at the pre-op appointment, if they were explained the process and why we're doing it, and even asking at this point if they're open to doing it, because a lot of patients kind of just want to get home after surgery. So this could be something that could speed up their hospital process, and we would teach them at their pre-op appointment.
Yeah, and we do recognize that that would be something that that patients would need to buy into, because it would be a finger prick, so there may be some discomfort. But at the same time, we're very hopeful that this is something that they would do, because compared to the alternatives that we had considered, such as expedited return to the emergency department, this should be more convenient and in the long term a less painful experience, because it's better than getting an IV line. So.
Yeah, 3 questions on.
Okay, so the first question is, have you researched follow-up appointment compliance? I think this could be a big risk to loss prevention. Additionally, is there any sort of move toward making these post-op vitals virtual? So we did talk about this. We are going to be looking at a specific patient population in post-op spinal cord decompression surgeries. After you have a spinal cord decompression, you're usually in the hospital for one night or you're released the same day. So basically, no matter what, though, you have to come for a follow-up appointment, because you have sutures that need to be taken out and they need to assess the alignment of the prosthesis that they put in. So no matter what, they would have to come back for follow-up. And do you guys want to address the second part?
Oh, it disappeared.
There's other.
Okay. There's something wrong with this.
Can we read that one?
Yeah. Is there a similar model to this for any other disease that you know of? And what are some lessons to be learned from that application of this model?
So when we talked to Dr. Slovis, he did a lot of work for the COVID home test kits. And he said one of the biggest issues there was that people were getting the kits, but they weren't actually using them once they got home. And the people who were able to go home with the kit probably weren't the ones who needed it the most, because they would recover. So we're hoping that by focusing on our very specific patient population of individuals who we know need to return at some point, but would like to avoid making that possibly 90-minute journey back to their provider to figure out, why am I feeling the way that I'm feeling? We're more hopeful that they'll be more motivated to use the test and adhere to those recommendations.
Yeah, and there has been another study, I believe in Kyoto, Japan, where they had a very similar kit for a different setting, which is basically they gave it to EMT trained specialists who would, and so there was I don't have the data on me off the top of my head, but there was quite a bit of benefit of getting lactate levels and pulse ox several hours before the attending could treat the patient who's brought into the ambulance. And so it has been shown that even if it's in a different timeline, that the kit itself would have some benefit in giving a heads up.
And then the last question is it a venous or arterial lactate sample? It's a venous. It's a finger prick point of care lactate test.
Thank you.
Thank you.
Great, thank you so much to that team for presenting their idea to us. That was awesome to have you all here, and then Rachel virtually as well. Our next team that we're going to hear from is E-sepsis, and that will be David, Eric, Sarah, and Adreja. So let's give them a nice welcome as they come up.
All right, so thank you for your patience. So like I said, we're going to be talking about our product E-sepsis. So a huge problem area under the umbrella of sepsis is the transfer of care of sepsis patients, whether it be from the emergency medical services to the actual hospital, within the hospital between levels of care, or intra-facility transport. And doctors and nurses and so many other medical professionals all agree that this process is both disorganized and chaotic. We spoke to a few doctors and nurses across a variety of specialties, and they all agreed that they hated being handed a stack of papers containing all of the patient's past medical history and medical information and having to sift through it to find the exact information that is needed for their sepsis care. In addition to this, a lot of patients who are coming from other hospitals or other facilities also have variable EMRs or electronic medical records. And so therefore the doctors and nurses also can't really access medical information super easily because of the difference in medical records as well. And so speaking to all these professionals, they all agreed that they would love to have a singular place where they can access relevant sepsis information so they can give care as fast as possible to the patients who need it the most.
So as you might imagine, with all that chaos and disorganization, our priorities and our methodology and approach to our design was really simplicity. We were very lucky to have a number of incredibly talented clinical side experts providing us insight and guidance throughout the process. Specifically, just want to acknowledge these folks here that you see up on the board, all of whom really gave incredible insight from their particular specialties. So from these conversations that we had with our experts, we ended up with this refined list of priorities. And again, they're all revolving around simplicity, ease of access, ease of use. Some of the issues that were raised in our conversations revolved around privacy. So this was something that we considered very early on. We want an easily accessible design, a document that can give you the picture of sepsis without compromising the patient's privacy. So one of our ideas was to eliminate any compromising protected health information from our design. We wanted to focus really on the high yield info that was most pertinent to sepsis. As I said, ease of use. And then luckily we'll get into this a little bit later with our team member, Eric, talking about some of our longer term goals, because we wanted to start with this use case of the pre-hospital transfer from EMS to the emergency room. But hopefully in the future, we can expand this to other transfers as well.
So after talking extensively with experts, we've designed E-sepsis, which is a QR code generated electronic checklist that can be attached to a patient wristband and given to patients by any healthcare professionals, including but not limited to ED physicians, nurses, and even nursing home care personnel. So E-sepsis is designed to encourage ongoing sepsis monitoring by serving as a reminder for healthcare professionals to check and recheck for sepsis on their patients. It also is designed to promote closed loop communication so that physicians and nurses don't have to spend time on the phone contacting the patient's previous facility or previous department. We really wanted to promote this closed loop communication so that healthcare providers who are taking care of our patients can easily access the information that is most pertinent to sepsis care just directly from the patient's room. And E-sepsis finally is designed to serve as an easily accessible cover sheet. So this also will bypass the problem of being handed a huge stack of papers and trying to find whether or not sepsis care has been initiated, whether sepsis has already been being monitored for. So we're going to move to a little interactive portion. So if you guys want to pull out your mobile phones, you can take out your camera app. If you focus your camera on this QR code, you're going to tap the link that comes up, and you can view our prototype of our E-sepsis checklist. So this is what a design of our user interface. So as you can see, as David mentioned, we don't have any personal identified health information on here. So you can see timestamps, you can see the location. So this will really help us help physicians and nurses know what the vital signs were at a previous location. So from the urgent care to the ED, and then furthermore, you can add to the ICU, post-hospital setting. So we're gonna have vital signs on there, and then treatment for sepsis, so fluid and antibiotics, also lactate levels, so you can monitor for important markers for sepsis. Of course, we're going to have suspected source, which can be updated. So as you can see, it was updated from the urgent care to the ED. And then we also have patient allergies and patient medications on there as well. And our idea is to kind of have a risk assessment scale. So if the checklist determines that there is no risk for sepsis, it should appear green. And if it's a high risk for sepsis, it will eventually appear red.
All right, so you might be thinking that the implementation of E-sepsis is a lofty goal, and you'd be correct. In order to move forward with next steps, we've broken it up into 3 bite-sized pieces. First, we focused on the security and HIPAA compliance of E-sepsis, and we've already started this process by removing protected health information. We want to make a secure platform that's also easily accessible for everybody. So we have to balance these 2 kind of opposing ideas by removing protected health information for now. We're also exploring other ways to increase security so that perhaps we can add more info back in. For implementation purposes, we want to start with the pre-hospital setting to include EMS like Philly Fire, as you can see on the right, and JeffStat. These 2 organizations bringing patients to the emergency department, that's where a lot of the breakdown happens because they use different EMRs. It's completely different environments. So that's why we think we have a big ability to improve the transition of care at that point. Next, we want to work on Epic compatibility, particularly for transferring patients within the hospital. So that would be from the emergency department to the ICU, across different levels of care, as well as between multiple facilities that use Epic. So just having that streamlined to kind of talk to providers' notes, we think will increase buy-in to this product. That's all that we have. We really want to thank you all for joining us, and we'd be happy to take any questions.
I like the simplicity of this solution and thinking why hasn't this been done before? Are there cases where in other healthcare services that we use QR codes, or is it because of a HIPAA issue?
I think that it's often. Oh yeah, sorry. So Vaughn asked us, why has this not been done before? Are there any other instances where we use QR codes in healthcare? And we have not found any other instances where they use QR codes. There are barcodes on patients' bracelets, as we've seen before, that kind of integrate into specific kind of like formats and everything that are specific to the hospital. We wanted to try and broaden that a little bit with the QR code. But I think that the security is part of an issue because anybody can scan it. So that's kind of what we've been working through for now. Also, it would be another step that doesn't necessarily talk to the EMRs that we're used to for now, like Epic, Image Trend that's used by EMS. So there's a little bit of a hurdle to jump over where providers may have to input data twice. And one issue that hasn't been completely fleshed out yet is disposal of the bracelets. Obviously, as it stands right now, they don't have that protected health information on them, but how do we responsibly dispose of them such that they're not found in a trash can where you can scan that barcode and check in with the patient status from long ago?
Yeah, I was curious about the actual hardware of making a machine that would, I guess, print out such a sticker or the QR code. Do you envision that being done in the EMS vehicle or also in different locations around the hospital?
Yeah, that's a great question. I think so. The question is about the actual hardware, the machine that prints out these bracelets.
We had talked about that a little bit. Hospitals already have the machine that prints out the bracelet. We were thinking that it could be implemented that a QR be added to that bracelet once we kind of figure out the issue of the protected health information and whether or not we can keep it alongside the QR code. So this would be something that EMS could input in the field, and then the QR code would be generated at the hospital so that that stays with the patient. A great question.
Have you looked into like any like passcodes that you would have to enter prior, like if you scan the QR code and then enter the passcode, like is that possible with QR codes?
We certainly did discuss that idea, including like a provider ID that might limit your access, right? It would have to be someone assigned to the patient's care team once they arrive. So yeah, these are things that we're constantly ruminating over right now. And that could obviously provide a barrier to the kind of the random access, right? The person on the street who just sees a QR code and can't help but scan it with their phone. Yeah, appreciate the question.
On one of your slides, you had mentioned like a risk scale from 1 to 10. Where you plan, like, is that something that already exists for sepsis, or is that something that like a doctor would kind of say like, okay, based on my clinical judgment, it's a 5 out of 10? Or,
I think, I mean, from what I could tell, we really initially have talked about like the color scheme. So having that implemented based more so on like what Dr. Gaieski was talking about, those criteria for sepsis, and then having it kind of be a color grade from green, yellow, red. Yeah, so the numbers were kind of on there to grade the color system, but yeah, that's a good question.
Yeah, QSOFA also has a scale that determines mortality. So there's like certain numbers that correspond with different percentages of mortality. So we could also implement that if that's more practically used in the healthcare setting.
All right, appreciate it very much. Thank you, guys.
All right, thank you, E-sepsis, for that great presentation. We're now going to take another short break, probably about 4 to 5 minutes. Feel free to step away from the screen, but if you do want to stay right where you are, we will actually have our sepsis trivia slideshow rolling through, so you can quiz yourself to see if you picked up any sepsis knowledge throughout the conference so far. And when we come back, we will hear from April Chavez, who is a maternal sepsis survivor and patient advocate who's here to share her story with us. So you don't want to miss that. So make sure you're back in about 4 to 5 minutes. And feel free to quiz yourself in that trivia. I didn't do so well the first time. So good luck, guys.
All right, so welcome back all. I'm so very excited to introduce our next speaker. We're very, very lucky to have her with us today, Miss April Chavez. April Chavez is a maternal sepsis survivor and now a patient advocate. After the birth of her son, April began to feel terrible. She reported her symptoms of sepsis, but it went unrecognized. After a failure to diagnose quickly, April went into septic shock and was placed into a medically induced coma in the ICU, where she fought for her life. Now she is actively working alongside advocates, nonprofit organizations, healthcare professionals, and medical experts to improve maternal sepsis recognition and outcomes. She serves as the maternal sepsis spokeswoman and board member of End Sepsis, the legacy of Rory Staunton, and is a member of the National Family Council on Sepsis. As part of the Maternal Sepsis Community Leadership Board, April is engaged in NIH-supported research designed to understand and reduce morbidity and mortality in maternal sepsis. As a maternal sepsis survivor and advocate, April's fundamental goal is to help educate others about the symptoms of sepsis and the importance of advocating for one's own health and the health of those around you. Please join me in welcoming April Chavez.
Good afternoon, everyone. I hope everyone can hear me and see me okay. Before I get started, I just want to confirm that.
Yes, that's great.
Okay, we're good. Okay, so this is a little bit strange. All I see is a hallway, but I'm gonna pretend like I'm there with y'all in person. I'll have to admit that I always forget about the time differences, and I'm in Texas. So I hopped on earlier and thought I was early, so I hopped off, and then I missed some of the presentations. So I'm gonna have to go back and rewatch them, but I wanted to thank y'all for inviting me to participate today. And thank you for such a great introduction. I'm really excited to be here. So I am April, and as mentioned before, I am a board member and very involved with End Sepsis, the legacy of Rory Staunton. Today, I just want to keep things very casual. I want to tell y'all why I'm so passionate about this and really just kind of make y'all understand what an important role that the medical community plays in impacting the lives of others and what a responsibility that is for a lot of different people. So let me take you back to the beginning. Okay, so my story started probably in about 2013, 2014. My husband and I decided that we were ready to have a baby. And we started trying and we were unsuccessful. We finally decided in 2016 that we were going to go and see a fertility specialist and kind of see why we weren't getting pregnant. So we went and we found out a couple of different things, and nothing on my end, I was fine, but we finally got to the point where the doctor said, listen, you're never going to get pregnant on your own. If you would like to have a baby, we need to take some interventions. And my husband and I both have a really strong faith, and we decided to just kind of step back and see, just kind of reevaluate, you know, maybe we weren't meant to be parents, or maybe this just wasn't the path that was chosen for us. So we kind of stepped back and just whatever happened, happened. Well, then we were pleasantly surprised in January of 2017, I actually found out that I was pregnant. And so we were over the moon excited because we did not think that that was going to happen at all. So we were thrilled. And you can see this is our baby announcement. My husband and I are both big baseball fans, and we love the Braves, and they won the World Series last year. I don't know if anyone else is a baseball fan. So yeah, we were very excited. Jumping forward to 2017 in September, we had our perfect little baby boy. His name is Cruz, and I was just the happiest person on earth. You can't tell in that picture because I was exhausted. But I was just, I never thought that we were going to have a baby on our own. So it was supposed to be the start of my little fairy tale. And I was so excited, and Cruz was perfect and he was healthy. Okay, great. I see that y'all are sharing the slides for me. Thank you. Okay, so happy mom. Great. Everything was moving right along. If we could go to the next slide, please. On the day that I was supposed to be discharged from the hospital, that is kind of where things started to take a turn. I started to just feel terrible. And this was my first baby. I had never experienced anything like childbirth before. So I didn't really know what was normal and what wasn't normal. I had a stack of baby books. I'm embarrassed to tell y'all how big it was, but I kid you not, it was probably this big. And I had read all about pregnancy, childbirth, everything that I could. And I knew that I was going to feel bad, but I was really feeling just awful. I felt like I couldn't catch my breath. I felt like my heart was racing. I felt like I couldn't stand without being exhausted. I felt kind of like brain fog. I just overall like had pain everywhere. I just did not feel good. I complained to doctors. I complained to nurses. Basically anyone who came in my room, I told them like something is wrong. I don't feel good. At one point I was like jackhammering because my chills were so bad, and they turned the thermostat up in my room to like 80 degrees. And then whenever my chills turned to sweats, they were like, oh, it must be something with your room. And they actually sent a maintenance person to come to my room and see if maybe it was just something that I was getting hot and cold because the air conditioner was not working properly. I mean, you know how hard it is to get maintenance in a hospital. They were doing everything they could except looking at my symptoms and really listening to what I had to say. So that was really frustrating. But as a first-time mom and somebody who I've always been fairly healthy. I haven't had to be in the hospital a lot. I didn't really know what all of my symptoms actually meant. I didn't know about sepsis. I had never heard that word before. So I thought maybe this is how all new moms feel after childbirth. Maybe I am just being kind of a wimp. So I let everyone convince me that this was normal, everything is fine. And eventually they sent me home. They sent me home with anxiety medication. And that was one thing that they kept saying was, oh, you're just anxious about being a new mom. Everything's fine. It's normal to have a higher white blood cell count after childbirth. It's normal for your heart rate to be a little high. So I believed them. I trusted in my doctors, and as much as I complained, there was always some sort of excuse or rebuttal about every symptom that I shared with them. So I believed them and I went home. This is when we brought Cruz home. I actually don't even remember taking this picture. I would never look like that in a picture when we're bringing our son home, but apparently I was not feeling well. So I went home and I did not feel better. I felt worse. I started to take all of the medication that they had given me, including the anxiety medication, thinking, okay, I'm gonna feel better. This is normal. This is how all new moms feel. But I wasn't getting any better. I started to feel worse. And so finally it got to the point where I started to keep a list in my phone. And this is actually a screenshot of my actual list from my phone that shows all of the things that when I was going to see my doctor next, because I had a scheduled appointment, I wanted to tell them, these are all the things that I'm feeling, because I was feeling so many different things that I couldn't even keep them straight. And I think part of that was also just confusion. So I started keeping this list in my phone. So I just kind of want to kind of cross compare these with y'all really quickly. The graphic on the right shows all the symptoms of sepsis that you all already know, but fast breathing. Yes, I had that. The shortness of breath, the skin rash and clammy skin, you'll see in my list somewhere in there. I had like pain in my leg and I thought it was like a bruise because it was really red. So I think that was part of that. Fast heartbeat, weakness, aching muscles. I couldn't go to the bathroom. I had that in my list. Feeling confused. I think that's why I had to keep this list, because I couldn't keep things straight. And normally I'm very type A on the ball. So that was not like me. And I still had the feeling hot and cold, shivering, and just couldn't keep myself balanced. And overall, I just felt terrible. When I was home, I remember bits and pieces of being home, and I couldn't care for my son. Like, they sent me home with a baby that I couldn't even care for. I'm very thankful that my husband was there, but I couldn't sleep. I couldn't get comfortable. I was just in pain. I was coughing up blood. And to me, it really speaks volumes to the power of the medical community, because during that time, I felt like I couldn't go back because they had already told me I was fine. I was literally coughing up blood, and I was afraid to go back to the hospital because they were going to tell me that everything was fine. And there's one particular instance that really stands out in my mind is when I was still in the hospital, I actually had a doctor tell me that I was being crazy and I needed to stop. And he said that so forcefully to me that it just made me feel like I'm not the professional he is. He knows what's going on. So there's so much power in the way that you treat people and the way that you interact with patients. It has the power to influence how somebody advocates for themselves later on down the road. So that was something that really stood out to me. So I went back to the hospital finally. My mom finally convinced me to go back, and I really didn't want to because I thought they were just going to tell me I was crazy. But I went back, and I went back to triage and labor and delivery unit. And I basically laid there and got sicker and sicker. They had no real answers for my family. They weren't really concerned at that point. It wasn't until I have very hard veins to find normally, but they couldn't find a vein to put an IV in me, and they called the rapid response team. And so the rapid response team came, and this young guy looked at all of my numbers and realized that something was wrong. And there is no doubt in my mind that without him, his name is Trevor. I don't know him. I've never met him because I don't remember that time period. But without Trevor, I know that I wouldn't be here today. So somebody standing up for me when I couldn't stand up for myself really saved my life, and I'm very thankful for that. But Trevor kind of broke protocol, and he took me up to the ICU himself because labor and delivery wasn't really looking for those things and wasn't really as aware of sepsis. I think they knew something was wrong, but I don't think that they recognized sepsis because I had already complained of those symptoms before I even went home. So I just don't think that they were keen on sepsis. So I was admitted into the ICU. This part of the story, I don't really remember a whole lot of. It's kind of been pieced together by my family mostly. But the ICU basically told my family that my odds of survival were not good because I was already in septic shock. They told my family to call my loved ones and let them come and say goodbye to me. And my sister lives 6 hours away, so she hopped in her car and she came. And of course, my mom and dad were here, and my husband was by my side through everything. But I just wasn't aware of all of that stuff that was going on because I was in a medically induced coma. The priest from my church came to pray over me, and it was just a really difficult time for my family. I always think of how hard it must have been for my husband. We prayed for this baby for years, and we finally got him, and now his wife was lying in a hospital bed on her deathbed, and he really had to think about how is he going to raise this baby alone, and how is this going to work, and how is he going to navigate life without me. So just by not listening to me and not taking my concerns seriously, it just changed the whole trajectory of my story. It just went from being a fairy tale to being a nightmare. And I know it's not my fault, but I always think, like, if I had known about sepsis, if I had just known the signs, if I had known just one thing about it, if I had read it in that book, I would have advocated harder for myself, because I really feel like I let professionals in my eyes convince me that everything was fine, and everything was not fine, not even close to fine. But I don't know how or why. I kind of know the why, but I survived. I know I kind of shocked a lot of people because the doctors did not expect me to make it. But I survived, and I did not lose any limbs. I did not really have any physical challenges to overcome. I did have to like learn how to rewalk and things like that in the hospital, but I'm here and I'm so thankful. Looking back on my experience now, there's a lot of things that I wish I would have known about maternal sepsis. As I got stronger and as I was moved from the ICU to kind of a regular room, a lot of doctors would come in and talk to me and say, well, it's so rare, this never happens. And I always asked, why didn't they listen to me? And one thing was, oh, it's so rare. And it's so frustrating to me now because it's not rare. Maternal sepsis is the second leading cause of maternal death. And I just want people to realize that just because something might be rare in their eyes doesn't mean that it can't happen. So that's one big thing. And another thing is, we live in the United States. We have access to technology and money and all of these things, but here in the US, our maternal morbidity rates are on the rise. So that's something that we as a country need to address. And another part of my story that I think kind of gets pushed to the side by myself is young women and women of color are more likely to experience maternal sepsis at much higher rates. And it's not because of genetics, it's because of things like implicit bias, racism, gender discrimination, whatever you want to call it, it happens. And I live in a predominantly white area of Texas. I'm a Hispanic female. I'm very educated. I have a master's degree, but I mean, you wouldn't know that when I was in the hospital. And I really feel like my care team treated me differently. And to me, that's extremely frustrating. And I don't want any other woman to feel that way. I know it can often be intimidating for a woman to speak up just in any medical setting. In my experience, I had a lot of male doctors, which normally I've never had a problem with, but I think that was part of why my experience turned out the way it did. I will never forget that doctor who was a male telling me, you're being crazy and you need to stop. So that's another part of my story that I'm really passionate about. If I could go back and tell my doctors something, the biggest thing that I would want them to know is just listen to me. I think if they had just listened or taken any of my concerns seriously, I would not have been in the situation that I was in. I mean, instead of calling the maintenance guy to come and check the air conditioner, like, listen to my symptoms that I'm telling you and go through protocols to see, could this be sepsis? They never mentioned the word sepsis while I was there. They never talked about infection. They never talked about any of that. It would have been much easier to rule out sepsis than to go down the road that I went down. I want medical professionals and care teams to really strive to create an empowering environment. As I mentioned previously, speaking up is hard. I mean, when you're in a hospital and that is not your area of expertise, you don't ever want to tell someone like, hey, I think you're wrong. Or if somebody has said a comment to you that's hurtful, like you're crazy, you feel this big and you don't feel like you are empowered to stand up for your own health. So these are kind of the things that I wish that I could go back and tell my doctors is just listen to me and work to prevent and treat an infection, know the signs of maternal sepsis, and create an empowering environment for, I'm very passionate about women and pregnant women or post-delivery, but I feel like sepsis can affect anyone. My experience was obviously with maternal sepsis, but I think these apply to all care settings. So now that I am stronger and more myself, it took me a while to get to that place, honestly. I think it was at the end of 2018, my mom brought me an old issue of People magazine, and there was a story in it, and it was about Rory Stanton and his experience with sepsis and how he lost his life. And I'll just say a little bit about that. So Rory was a young boy who got a scrape in gym class, and he ended up getting sepsis, and it went unidentified. They did do the test, but the results weren't passed along in time. And he ultimately lost his life to sepsis. So my mom brought me that magazine article, and of course it just made me cry. And my heart went out to his family, just because it's not something that any mother or family should have to go through. But I started following, at the time it was a different organization name, but now it's In Sepsis. I started following them on social media, and I started just reading more, and I started joining groups and just kind of lurking. And then finally, I got brave enough to share my story, and Orla, who is Rory's mom, reached out, and we kind of connected. And just hearing her and hearing how difficult her journey has been, but how she's turned her journey into something positive. I mean, she had a tragic loss, losing her son, but now she is advocating and she's leading this great organization. So I decided to get involved with them. And since then, it's kind of been like a healing process for me. It makes me feel good to help other mothers realize that things can go wrong, and just kind of know that everything is not always picture perfect, and you need to be aware of those things, and you need to advocate for yourself. So yeah, that's kind of my journey. And the last thing that I'll leave y'all with before I provide an opportunity to ask questions is, I wish I could tell this to everyone. Listen to me and her and all of the other women that you'll encounter in your future careers. So that's it. Thank y'all.
I will ask you a question then, April. So
okay.
I'm curious, of course, the bulk of us here in person are medical students. And certainly it has been emphasized to us, the art of listening. Is there any other particular advice? So besides, that's something that doesn't necessarily come easily, right? What is the practical decision that you should make when you enter the room and you're about to talk to a patient? What's your advice for how to listen in the best way?
I think just empowering them to voice all of their concerns and not kind of interrupting them when they're talking and not dismissing their concerns. There is, I mean, doctors told me, oh, a white blood cell count is normal after childbirth. Well, yeah, it can be, but it can also be a sign of something else. And I just wish that somebody would have used that as an opportunity to actually take action and rule things out instead of just kind of brushing it aside verbally. Like, take some sort of action just to double check. So that's kind of my advice.
I really, really appreciate it.
Thank y'all so much. This was great.
Let's have one more round of applause for April. Really, really, truly cannot thank you enough for being with us here today. It really was a true treat, a remarkable, remarkable story. And thank you also so much for your continued advocacy and research and work with End Sepsis. It's completely fundamentally vital, and we are really, really grateful to you and your work. So we are going to get moving right along again. We have 3 more student presentations to wrap up our conference today. And we are going to start with the point of care lactate team with Lawrence, Jessica, Andy, Joel, and Erica.
Hello, everybody. Thank you for coming to our talk. Our talk today is about redesigning sepsis, more specifically about point of care lactate. Okay. So we wanted to, I wanted to build a framework in which to think of our problem. So we wanted to talk about what is sepsis first. And so, as mentioned before, sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. And we think the best way to think about our problem is through a classic scenario in the ER. So if you imagine a septic patient who comes into the ER, and we all know that ERs are very infamous for their very long wait time. And so it takes a very, very long time to get IV access because due to lack of resources such as understaffing, lack of beds, and patient overload. And so once the patient is seen, the healthcare professionals through criteria such as SIRS. If they suspect sepsis, then they can run lab tests through this IV access, such as lactate. And lactate is one of the markers in which we diagnose sepsis. And this takes a short time, but the real problem is the long wait time to get the IV access. And so us as a team, we're thinking about how are we going to circumvent this problem and shorten the time in which we can get lactate levels. And so why is delaying diagnosis of sepsis a problem? And so sepsis is a time-sensitive issue. And there are numerous studies that show that delayed administration of broad-based antibiotics is associated with higher mortality in sepsis. And so we can see this paper by our very own Dr. Gaieski, and that shows that the impact of time to antibiotics is a big marker in which survival rate is dependent on. And we can also see from this chart that antibiotic administration decreases the likelihood of death by 7.6% per hour. And so this is the framework in which we thought of our project. And so I'm going to move on to the current solutions.
So currently when a patient comes in, we can evaluate them using the QSOFA criteria. So we're looking for an altered mental status. So GCS below 15, a high respiratory rate, and a low systolic blood pressure. But as Dave said, or Dr. Gaieski said earlier, this is not very sensitive. So if a person has two of the 3 criteria, they're said to have a positive result. And it doesn't diagnose them with sepsis, but rather indicates that they potentially may have sepsis. But it's not very sensitive. So there is a group of patients that are going to fall through the cracks here and are not going to be identified as being at risk for sepsis. And so these patients are patients that are sick, but don't appear as sick as the other patients. So you don't really worry about them as much. And so they may wait a longer time in the ER. And so additionally, we need to get those serum lactate levels. But as Larry mentioned, those are IV access. So if this patient has a long wait time, you're delaying the time it takes to get those results of their serum lactate, which could catch the sepsis that we didn't catch earlier using the QSOFA. And ultimately, we're delaying care, which is potentially dangerous for our patients.
So with the inefficiencies we see with the sepsis workflow in the ED, it begs us to ask a question, there's got to be a better way. Our team thinks there is a better way, but maybe it's in a world outside of sepsis. So a lot of you probably recognize the device in front of you. It's a point of care glucometer. Basically the way it works is you get a little drop of blood, you put on a slit, you put it in the machine, and then you have your serum glucose. And these are wonderful because they're easy to use. You get immediate results, right? And again, you don't need that IV access. You just need a drop of blood. So what if there was a world where we could measure lactate the same way that we measure glucose, but maybe already live in that world? This is the Lactate Pro. It's one of a few devices created that take a lactate the same way that you take a glucose. And our idea is that what if we took some of these devices and put them in specifically the Jefferson ED, and because we're able to take a lactate faster and more efficiently, we could stratify patients better in order to give antibiotics to those that need it the most. But this does beg a few questions, such as, would this stratification even work? How accurate is this compared to a lactate taken in the lab? And those are some things we want to address.
And so with that, we have some evidence to support the addition of a lactate pro into the emergency care setting. And so this research that you see before you is based on tests by Dr. Gaieski and additional members. But basically, this is research that has been done with the Lactate Pro analyzer tool. We already know that lactate is used to stratify patient illness severity. In general, an elevated emergency department level of lactate is an indicator of increased likelihood of death. And so point of care lactate devices at emergency triage may actually represent a useful method for early identification of lactate levels in septic patients. And so within the study, importantly, and what is our main focus moving forward is that the time to triage using the point of care lactate versus time to triage when doing a normal blood lactate, which is getting it from a venous sample, which then has to go to the lab rather than just being done on the spot. Using the point of care lactate, it decreased test result times by 2.5 hours, which is huge with something so time sensitive such as sepsis. And so basically, we're hoping to approach sepsis as a time-sensitive illness, like we might approach a stroke or someone who has a heart attack or an MI. Just because someone might not be showing visible symptoms with sepsis doesn't mean that we can't detect it. So basically, it works. There is evidence to support that the fingertip point of care lactate is effective. It was found that this could be a screening tool that provides real-time results to providers. Overall, these tools could be used to reduce the time to obtain test results. And there's also time-sensitive therapies included in sepsis are using antibiotics and also aggressive fluid resuscitation. So if we can start that earlier, we have more opportunities to mitigate death. And furthermore, and finally, I'll just mention that this QSOFA score from this JAMA 2016 article mentioned that hyperlactemia or elevated lactate did not meaningfully improve predictive validity of QSOFA. However, in the patient population studied, there was hospital mortality significantly higher in patients who had fluid-resistant hypotension that required vasopressors and also hyperlactemia. So basically, our argument and hope for this implication is that combining the use of high lactate scores and the QSOFA can prompt better consideration of patients who were not previously or who might not previously have been recognized as septic in an emergency situation. And we hope that the addition of these lactate devices in combination with a less specific thing such as the QSOFA score will decrease mortality rates.
In terms of limitations or barriers to our project. So the main one actually is that Lactate Pro is not FDA cleared in their F10K for clinical use. It's only meant for over-the-counter use. That's why it's CLIA waived. But essentially it's used for athletes to test their lactic acidosis during training to see if they're hitting certain thresholds. So that's the reason why people don't do this already. For us, that's fine because we're planning to only do a pilot study. So we're not terribly interested in whether the actual lactate readings are clinically actionable, because that's not the question that we're trying to answer right now. Recently, there actually was a device created by Nova Biomedicals called the StatStrip Lactic Express that did receive FDA approval for hospital use. However, it's not sold yet in the US. There are also more granular concerns with making this kind of study. For example, sepsis has 850,000 ER admits a year. but it's still less than 1% of sepsis, still less than 1% of ER visits. So the question then becomes how you design a high power enough pilot study to capture enough sepsis patients that we're looking for are certain subpopulations that may have a longer time to lactate test. And then we can talk more about this later after the pitch. But I think we're out of time. So we would love to take any questions that you have about our project.
No.
Oh, I think we have a question in the audience.
In terms of the clinical spectrum of stuff, like do you imagine administering a point of care lactate test in the emergency room?
So at Jefferson, glucose glucometry is done at the triage room. So patients after going to the triage desk have to wait in the main waiting room to get the triage, and the triage attendant will see them. So we anticipate the triage attendant would also administer a point of care lactate because it also takes around the same amount of time that a glucose strip would take.
Are there concerns about overdiagnosing sepsis with falsely elevated lactates?
That could be a concern. Right now, we're mostly concerned with decreasing the time that it would take to even get a lactate level in the first place. It's been shown that the finger strip lactate tracks well with the plasma lactate. So as a screening tool, obviously overdiagnosis is always a concern, but right now we're thinking more about, we're trying to track a certain subpopulation of sepsis patients where they come to the emergency room, but as Dr. Gaieski mentioned in his initial talk, they may have bacteremia, but they may not have all the SIRS or Q-SOFA criteria. So they are sitting there waiting for hours because no one thinks they're a big deal, and then they might progress through the septic pathway without anyone really noticing. So that's really the demographic that we're trying to capture, and we're trying to quantify that using some retrospective studies right now.
Yeah, and then I just wanted to say, like the Q from the research, from what we looked into, the Q-SOFA actually is a good tool, but it's just it is more robust of a tool with the addition of a lactate test, and so by speeding up that process through a finger stick test, that is truly the value of its implementation.
Okay, thank you so much, point of care lactate. So we're gonna take our final just 3-minute break very quickly, grab some water, stretch your legs, use the restroom, last chance, and then we'll go ahead with our final 2 groups. Thanks. All right, thank you all and welcome back. We're gonna go ahead with the final portion of our conference. So first up is Sepsis Shield, and we're gonna hear from Kiernan, Chitra, Abi, and Mengi.
Hi, everyone. My name is Chitra, and along with Kieran, Abi, and Mingy, we're excited to present to you our project titled Sepsis Shield. So with that, let's go ahead and get started.
So we're just going to start with a little bit of a patient story that I'm familiar with through a family friend. So let's talk about a 17-year-old boy, high school athlete, varsity wrestling team, gets a cut. Those mats are probably not known for being the cleanest places ever. Ends up getting an infection, goes to an urgent care center with lots of persuasion from his parents to get regular wound care, make sure everything was okay, is given the appropriate things and sent home. Then returns to the emergency department a few days later, feeling sick, slight fever, heart rate's a little high, not feeling too great, is again told that the wound looks fine and is sent home. Condition continues to deteriorate. He returns to the emergency department and ends up in septic shock. Has to spend a couple of weeks in the ICU and eventually does recover, but it is a long road. So where did we go wrong? Where could this have been stopped? Why did this person end up in the ICU? That's the exact question that we're trying to answer today with Sepsis Shield. Occult sepsis patients are patients who are well appearing upon presentation to an emergency care department or emergency department who are still at high risk of becoming septic. These patients likely have near normal vitals or unchanged mental status despite being at high risk for sepsis.
So why does this matter and why is our team specifically interested in occult sepsis? Well, as some of you may know, 1 in 5 deaths globally are due to sepsis. Of these sepsis patients, 50 to 60% of potentially septic patients initially go undiagnosed with occult sepsis in the ED. So, you might have a patient, they might be treated, and they might be sent home only to return with signs of sepsis or even in septic shock. So with this number, and it's quite a staggering number, it really shows us that early detection of occult sepsis has the potential to improve clinical outcomes tremendously. And as we've learned before from a previous presentation, 7.6%, or there's a 7.6% increase in patient mortality for every hour that sepsis treatment is delayed. So the earlier that we can identify occult sepsis, the better patient care that we can provide.
So our solution for detecting occult sepsis earlier is Sepsis Shield. Sepsis Shield is an app-based questionnaire that patients can fill out while in the ED and the urgent care. So our app will ask questions for patients regarding their past medical history and history of present illness so that we can create a risk classification for sepsis based on clinical factors. And in combination with laboratory values, we're able to detect patients with sepsis who will normally fall through the cracks in the busy ED or urgent care settings. So here's a general quick look at the current clinical workflow. So typically patients with occult sepsis will first present to the urgent care because they don't feel sick enough to go to the ED. So at urgent care, they're going to be prescribed antibiotics or provide some sort of treatment that just isn't sufficient enough to clear their infection. So as a result, a couple days later, they're going to end up in the emergency department, likely in septic shock. And similarly, in a different scenario where a patient goes to the ED first instead of the urgent care, they're going to end up being met by a triage nurse who's going to assign them an ESI score and emergency severity index, as well as take their chief complaint. And from there, they're going to go in the waiting room and wait for the physician to be seen, to see them. So the ED physician is going to take their history of present illness as well as place an order set. Then the patient's going to get their labs taken. They're going to go back to the waiting room and have to wait there. They can wait there for up to 24 hours before finally being treated or admitted into the ED. So these two long waiting periods are where patients with occult sepsis usually crash. And our goal is to be able to identify these patients early so that they don't have to suffer through the waiting time. So our idea with Sepsis Shield is to implement them in the urgent care setting or in the waiting room during triage at the ED. So in the urgent care, patients who, we plan to implement Sepsis Shield in order to detect patients who are at risk for being sepsis before they become actually septic. In this situation, we can take these at-risk patients and bring them to the ED where the triage nurse will already been notified that they are at risk, so the admission process is sped up. In the ED, during triage, patients are also met with registration who here at the Jefferson Hospital will register them for the Jefferson My Chart app. And so here we can also prompt them to download the Sepsis Shield app in which they can take the questionnaire and fill it out while waiting to be seen by the ED physician. And if detected to be at risk for sepsis, they can then be, their admission process will be sped up, and then they can, so that they can be taken care of before they actually crash.
Thank you, Mengi. Now I'm going to quickly go over the clinical factors as well as the future direction for our project. So as we've already talked about, there are several systems already in place, such as SIRS, which currently do not capture all of the septic patients, and especially for occult sepsis, is still lacking. So we are not trying to reinvent the wheel here. We have found several machine learning algorithms, such as ESPM, in the literature that do a better job of encapsulating, based on lab values and vital signs, the full spectrum of sepsis patients. Ideally, once these are more tested in the field, they will be incorporated as the base of our app So then our actual innovation beyond the early workflow intervention is to actually introduce some extra clinical factors that might not be seen as often or taken note of in the initial ED appearance. Something as simple as high blood pressure, where if someone has a history of high blood pressure, then if they have normal or even low blood pressure, it's even more alarming. And obviously we'll have to prove these factors, which is why one of our next steps is to do a clinical research study where we take a population of septic patients, work backwards and see if some of these not as studied clinical factors actually do correlate to sepsis. And these factors would be beyond just the labs and the vital signs that are in the literature for today. And those findings would then be the foundation for our application so that it can better risk stratify patients based on their sepsis risk. And that is it for us today. So thank you all for listening.
Would this app be directed by the clinical team for patients to download, or would it be widely available for any patient or population that is concerned about cold sepsis?
Right, so I think the application that we were initially thinking of is upon presentation to an urgent care. So let's say you show up to like an urgent care setting, you've had a fever for the past day or two, you would be prompted to then download the app and fill out the registration, fill out the survey, and then that information would be routed to your care team, and similarly in the ED. So upon arrival to the ED, you're met in a line, and then you go to the registry, the triage nurse and the registration person. Again, that would be where the person would be prompted to download the app. I mean, I think the issue with the cold sepsis is we could then be over-diagnosing if everyone has access to this app. But I think that definitely would be long-term goal of other application settings. We've talked about also how it could be used in maybe a rural or urban setting where there's less resources and the wait times are a lot longer in EDs, or even integrating it into a telehealth setting. So I don't think it's intended to be for the general population, but different clinical settings would definitely be critical for getting the app out there. Yeah, Zach.
I'm just wondering for the machine learned drug algorithms, will those better at identifying sepsis and criteria looking at retrospective data or as like interventional?
Right, so they're made based on retrospective data, but they're recently being used in hospital systems. So actually the ESPM is what's used in Epic right now, and it's being like slowly integrated. So that is already happening, which is why our innovation is more like these other clinical factors that are at the initial ED visit that could better diagnose.
Do you know of any interventions which have involved patients downloading an app as they are admitted in the past? Just because I'm curious about like how willing people are to download stuff onto their phone.
Yeah, so the question was about other times when you prompted people to download an app upon arrival to a clinical setting. I mean, I think COVID's a pretty perfect example. We're constantly being prompted with COVID questionnaires, and whether that's being done digitally or through a paper screen or a paper screening, I think the app allows us to have that information then directly routed to the EMR, which you obviously can't really do easily with like a paper format. But I think COVID is a perfect example where we were asking people questions and are medically sensitive right away. We have talked about some of the hiccups of people being willing to download apps. I think generally we talked to a nurse in the ED and she said 90% anecdotally probably of patients who come in the ED have a smartphone and would have that capability. For patients that either don't have that or maybe need some other assistance with getting that app, we would hope to have iPads available with the app already installed as well. So that's kind of another hurdle that we're looking at. But I think most people with the tech savvy that we've all grown up with would be willing to download the app.
But you are right that patient education is an important component of implementation. So that's definitely also something we would consider moving forward.
Well, thank you all for listening. We appreciate it.
All right, thank you so much, Sepsis Shield. Last but certainly not least, we have SepSensor team is going to present, and we have Sam, Joseph, Julian, and Lynn.
Great, thank you so much. So
we are the last group to present, and we'll be talking about SepSensor. So I'm Sam.
I'm Julian.
And I'm Joe.
And together we're SepSensor. So you walk into the emergency department. What do you hear? Probably something like this. You're overwhelmed with this constant amount of beeping and all of these other distracting noises that you hear. This can lead to a phenomenon well studied in the scientific literature known as alert fatigue. Additionally, there's several other problems in the ED. There's a lack of standardization among providers and different treatments being provided to patients for sepsis, despite really having the same general sequence of care that you need to cover for every patient. Additionally, there's lapses in communication. For instance, on the fly, you're kind of going by word of mouth, but eventually, as we know well, everything needs to be documented in the electronic health record. Currently, we're stuck somewhere about in the 16th century with our pager system that's used. This is very outdated, and even though there are more solutions that are out there, they're not often implemented. One of those solutions is an Epic order set, such as the one that we use at the Jeff Hospital system. And this allows clinicians to sort of automatically pull up all of the orders and things that they would need for sepsis. It's called Severe Sepsis Order Set in Epic. So what we really need is an ideal solution that's integrative, comprehensive, and not overwhelming. Additionally, clinicians have provided a lot of insights into the sort of things that we need to incorporate when designing a product. So, for instance, one emergency medicine physician and medical education fellow, Dr. Kem, said, with all these beeps and alarms, I can't even hear myself think sometimes. As we saw at the beginning, this is really pretty overwhelming for any sort of clinician working in the ER. Additionally, integration of care is key. As Dr. Bright, the HHS Deputy Assistant Secretary for Preparedness and Response said, solving sepsis requires taking a holistic approach to this national threat. What we really need is something that can streamline care across all healthcare providers.
In fact, streamlining care has been shown to improve outcomes for patients. A study showing comparing patients who are compliant with a standardized guideline versus non-compliant with the standardized sepsis guideline showed a lower 30-day mortality. This demonstrates that adherence to these standardized guidelines can prevent avoidable deaths. So these guidelines have been evolving over the past 2 decades. As the importance of rapid intervention has become more clear, the time frame for these guidelines has shifted from 24 hours down to a 1-hour sepsis bundle. The current Jefferson order set closely mirrors this 1-hour sepsis bundle, consisting of 4 main components: IV fluids, an ED sepsis evaluation containing vital signs and labs, as well as antibiotics and vasopressors. Together, this 1-hour sepsis bundle set forward by the Surviving Sepsis campaign and the current Jefferson order set serve as the basis for our SepSensor, which Julian will now explain.
All right, so this is a general schematic of our solution, which is a LED panel, and this would go outside of the patient rooms. And when designing this, we wanted to really emphasize simplicity as well as parallel the order set for sepsis treatment in the ED in Epic. So first, of course, we have lactate. This is very important. So it's an indicator of hypoperfusion and cellular dysregulation. So you want to obtain those levels immediately when a patient's been identified with sepsis. Then you want to obtain blood cultures. So this is our second column here, preferably before you administer antibiotics. And then you want to start a fluid resuscitation. And then also, if the initial lactate level was greater than 2 millimoles per liter, you want to perform a repeat lactate level to assess the progress of the progression of the disease. And then if the fluid resuscitation is not relieving the hypotension, then we want to administer vasopressors, which is the 6th column. And then finally, we want to perform a final perfusion assessment. So each of these columns has can be 3 different colors: red, yellow, and green. So red just means that it has not been completed. Yellow means that it's in progress in some kind of way. For example, with antibiotics, the yellow color would mean that the antibiotics have been ordered but not yet administered. And then green means it has to be completed. So the goal for this set is to have all greens, and this kind of ensures they
continuous positive feedback loop. So what does it actually look like in the ED is actually pretty quite simple. So clinician enters an input into Epic, that correlates to a change in the LED sensor on the outside of the room of the patient, and then that correlates to an action taken out by the clinician. So this is a continuous feedback loop that's continuously monitored to ensure that each step in sepsis is being completed to its full extent. And finally, in terms of like future progression of this device, like our main thing is we want to be adaptable. So we want any changes in Epic to correspond to changes in the LED. Fortunately, LEDs are actually pretty simple to program if you're an engineer. Second, especially incorporate artificial intelligence. So leverage big data to improve our system in some kind of way. And then thirdly, we need to address any problem areas that we might have from clinicians. So that can either be with the sensor itself or the process flow of the integration of the system or both.
So looking to the future, we want to define the measurable outcomes for our SEP sensor, as well as collecting additional feedback from the clinicians and nurses who will be using our SEP sensor so that we can use that advice to create a prototype device while also moving towards integrating with Epic so that ideally sometime next year, we can get started testing in a hospital setting. But that's all we have for you, so. See if there are any questions. So the question is, this is available in Epic today in case this team ends up wanting to pursue the project. Yeah, so there are existing solutions like this within Epic, but we wanted to create something that was existing in the physical world so that anyone who's treating the patient would have to see it physically and not have it be something where you could just dismiss it quickly in Epic, which is a problem that occurs in real life.
Any other questions? All right. Oh, yeah, Chitra.
So is this tool mostly for clinicians or would there be kind of like a patient-based development? Like explain what the lights need or I don't know if you guys have that.
So we envision this being like on the door. So it's kind of like a non-intrusive way of informing providers. So not really meant for patients, although definitely could be very easily explained to them. Like, here's where you're at right now. This is yellow, everything else is green. So let's try to get you to all greens. Yes?
Could it possibly also be implemented like a reverse side inside the room so it can be used for patient education in their own advocacy and moving through like the healthcare timeline?
That's a super good idea.
That's a really good idea.
Yeah, you can put it as like a.
Glad you're doing it.
Yeah, so that's definitely something we can consider. We've really like tried to focus on like the provider experience because when we were defining our problem area, we wanted to make it as specific as possible. But I think given the proper implementation, you could really use this for patient education as well. All right, thank you.
All right, thank you again, SEP Sensor, for closing us out. It's like such a great presentation. And thank you to all of our student groups today. Let's acknowledge everyone real quick one last time. I know I speak for all of us first-year med students when I say it's been a true privilege to learn about and experience firsthand the health design process this year in the Health Design Lab, especially alongside such accomplished members of the field. It really has been an absolute privilege. And I know these are skills and abilities that we're going to be taking with us in our future careers as physicians. I do want to acknowledge a number of our leaders in the Health Design Lab. Our instructors and support systems really made all the difference in the world. So I particularly want to call out our program director, Dr. Morgan Hutchinson, Dr. Bon Ku, who's in the audience with us, Dr. Kelly Kem, Dr. Rob Puglisi, as well as our superstar of special projects, logistics, and administration, Mary Ellen Daly. Really, really could not have done it without you guys. So thank you very much. These projects neither would have been possible without the incredible slate of clinical experts and outside of clinical experts and consultants that we had at our disposal throughout the entire process. They really guided us through from our very first early planning stages and made the refinement and consolidation of our ideas a real reality at this stage. More work to be done, of course. So thank you so much to all of our clinical experts. It may surprise some that this conference was also designed chiefly by us, the students. So there's a number of us who served on an organizing and planning committee. I want to thank everyone who was on that committee, and in particular our co-directors, Parth and David. That is another David, it's David Gordon, not meant to be self-congratulatory. Thank you very much. And then really, most especially, I want to thank Dr. Dave Gaieski and Ms. April Chavez for their contributions today. Really invaluable work that they did. And I think both of their pieces really enhanced our entire experience of the conference today. So thank you both so much. Dr. Gaieski is also one of our clinical experts, and of course, in a leadership role in critical emergency care. So he's really at the frontiers of improving our outcomes in sepsis here at Jefferson. And then April, I really think like April's experience, her advocacy, and her perspective are things that we really all have to emphasize and hold on to now and moving forward throughout our careers. It's such an important reminder that at the core of every case of sepsis is a vulnerable and suffering human being. So learning to listen and remembering to listen thoughtfully, completely, as April emphasized, and empathetically is going to remain at the core of our improvements in sepsis care. Finally, I want to give special thanks to the rest of the Health Design Lab, and in particular, Kayla, who really helped maintain our entire logistical system up here at the front. Could not have done it without her, so thank you very much. Yeah. And then finally, I just want to thank our virtual audience. Really made the conference a reality and something that we're excited to work towards. So thank you all for being here. I'm really grateful and optimistic about all of the energy we put on today to solve a really difficult problem in clinical medicine right now. It's something that has at times appeared really resistant and even intractable with improvements that we've seen in critical care and clinical medicine at large. So we need to keep striving and maintain this energy in creative thinking and health design to improve sepsis care in the long term. We really hope that everyone leaves today with some valuable new health design wisdom and a feeling of recommitment to redesigning sepsis care, keeping in mind that all of our patients now and in the future will be those that benefit. So thank you all so much on behalf of myself and Kieran, my co-host, of our co-directors, Parth and David, excuse me, and the rest of our first year students. Thank you all so much and best wishes.